welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Hello, my name is Caitlin Lemmons, and I am a first-year pharmacy resident at Nebraska Medicine. I am going to present today on four-factor prothrombin complex concentrate versus Andexanet Alfa for the reversal of DOACs in traumatic brain injury. To begin the presentation today, I have no financial relationships to disclose. The topic of Andexanet Alfa versus four-factor PCC is a somewhat controversial topic and very large to cover in a relatively short amount of time. So today we will just briefly review the background of four-factor PCC and Andexanet Alfa. We'll summarize some of the previous literature comparing these two agents, and we'll evaluate a new piece of literature for DOAC reversal in the setting of a traumatic brain injury. Our direct oral anticoagulants, or DOACs, include the direct 10A inhibitors, apixaban, sold under the brand name Eliquis, and rivaroxaban, sold under the brand name Xarelto. DOACs have changed the landscape of anticoagulation, largely replacing our vitamin K antagonist warfarin for the majority of indications. While relatively rare, the annual incidence of intracranial hemorrhage in patients using a DOAC is 0.1 to 0.2%. And again, while rare, intracranial hemorrhage does carry a mortality risk of 40 to 65% after 30 to 90 days. When we directly compare Andexanet Alfa and four-factor PCC, we see that they differ in their mechanism of action and FDA approval. Andexanet Alfa is a recombinant coagulation factor 10A that binds and sequesters our factor 10A inhibitors. Andexanet Alfa is FDA approved for the reversal of DOACs. On the other hand, four-factor PCC works by replacing depleted clotting factors as inactive 2, 7, 9, and 10, plus antithrombotic proteins C and S. When four-factor PCC is used for DOAC reversal, this is an off-label indication. When we look at cost comparison per patient, we can see that for a low dose of Andexanet Alfa, it's approximately $13,000, and for a high dose, it's approximately $23,000. When we look at the use of four-factor PCC, a 2,000 unit dose is approximately $7,000, while a 5,000 unit dose is approximately $18,000. While Andexanet Alfa has become more affordable from a healthcare and patient standpoint, we do still see a difference in the price between these two agents. And many hospitals have been hesitant to add Andexanet Alfa to formulary as the primary agent due to a lack of superiority and cost. Included here are the box warnings for both of our agents, and this includes arterial and venous thromboembolic events and ischemic events, including myocardial infarction and ischemic stroke. There are two sets of guidelines that provide some guidance on DOAC reversal. These include our American College of Cardiology, American Heart Association, or ACC/AHA guidelines, and our European Society of Cardiology atrial fibrillation guidelines. Each of these guidelines states to administer Andexanet Alfa or a specific antidote, or if unavailable, to administer prothrombin complex concentrate. When we consider some of the efficacy studies for four-factor PCC, think about that by Shulman and colleagues and that by Panos and colleagues. In each of these studies, we saw that the majority, if not all of the population, had an intracranial hemorrhage. And when we look at the primary outcomes that were evaluated, they were related to hemostatic efficacy. The ANNEXA-4 study was a prospective single-arm study that evaluated percentage change in anti-factor 10A activity from baseline, as well as hemostatic efficacy. We saw approximately 70% of the enrolled population there had a CNS bleed. I included this timeline here just to show a sample of the comparison studies that have been completed for Andexanet Alfa and four-factor PCC. You can see Kcentra, which is one of our four-factor PCC agents was approved in 2013, and Andexanet Alfa was approved in 2018. When we look at a selection at some of the most recent comparison studies, we can look at that by Pham and colleagues, that by Costa and colleagues, and that by Sutton and colleagues. These were all retrospective reviews. We saw a difference in the dosing strategies for four-factor PCC that were evaluated. In terms of enrollment, our largest study by Sutton and colleagues had 255 patients. And when we look at outcomes, we saw a variety, including hemostatic efficacy based on the International Society of Thrombosis and Hemostasis criteria, Annexa-4 hemostatic efficacy criteria, and mortality. There are ongoing limitations with all of our retrospective reviews that limit applicability and the ability to draw strong conclusions. Some of these limitations include sample sizes, a variation in the clinical outcomes that are evaluated, and our four-factor PCC dosing regimens looking at fixed versus weight-based dosing. I want to come back to our evaluated outcomes here. For all of these retrospective reviews and trials, we would like to see clinically relevant outcomes like death or hospice and functional status on discharge. And as we look to this new piece of literature, this was a retrospective review by Sadik and colleagues that was published in 2024 in the Emergency Medicine Journal. This retrospective review included 35 different trauma centers in Michigan and Minnesota. They evaluated Andexanet versus four-factor PCC. We saw a population size of 324 patients, with 265 receiving four-factor PCC and 59 receiving Andexanet Alfa. When we look at primary outcomes, this included mortality or hospice at discharge. And for secondary outcomes, we saw a composite of serious hospital outcomes. Key inclusion criteria were adults at least 18 years or older, having a traumatic mechanism of brain injury. They had to have a head abbreviated injury scale of greater than 2 and an injury severity score of at least 5. And we'll touch on these scales on the next slide. Patients had to have factor 10A use within 2 days, and they had to receive Andexanet Alfa or a four-factor PCC within 24 hours of presentation. Key exclusion criteria were admission from an outside hospital, P2Y12 inhibitor use, an abbreviated injury scale greater than 2 outside of the head, no signs of life on initial evaluation, receiving both Andexanet Alfa and four-factor PCC during admission, and having a history of a bleeding disorder or thrombophilia. When we look at the different injury scales that were used, we have our abbreviated injury scale, and this enables the ranking of injury severity and correlates with patient outcome. So injuries are assigned a code based on anatomical site, nature, and severity. This scale ranges from 1 being a minor injury to 6 being an unsurvivable injury. If you remember from the previous slide, patients had to have an head AIS greater than 2, 2 being a moderate injury. When we look at our injury severity score, this takes the 3 highest abbreviated injury scale scores, squares them, and adds them together so you can see the calculation that would be used below. This score ranges from 1 to 75. Any patient who receives a AIS of 6 or unsurvivable automatically receives an injury severity score of 75. The injury severity score correlates with mortality, morbidity, and length of hospital stay. And it's also a consistent risk factor predictor for post-injury multiple organ failure. From a demographics standpoint, the groups were well balanced with a mean age of around 80 years old, approximately 50% of patients in each group being male, and more than half of individuals in each group experienced a subdural hematoma for our injury type. While P2Y12 inhibitor use was listed as an exclusion criteria, approximately 40% of patients in each group did have aspirin use at baseline. When we think about the severity of injuries, we can see that patients within the four-factor PCC group were significantly more likely to have a motor GCS score of 6, which means they were a bank bands. When we look at our injury severity scale, patients were significantly more likely in the four-factor PCC group to have a lower injury severity scale number, with 5 to 15 correlating with moderate. Nearly 50% of patients in our Andexanet Alpha group had a injury severity scale of greater than 25. But I do want to point out our population size differences, where there were still twice as many patients in the four-factor PCC group also having that injury severity scale greater than 25. And when we look at our head abbreviated injury scale, see that significantly more patients within our Andexanet Alpha group had a higher head AIS. In terms of results, the authors looked at an adjusted odds ratio. And just to remind you, anytime the range includes the number 1, this means that our odds ratio crosses the line of non-significance. When we looked at death or hospice, approximately 20% of patients in the four-factor PCC group, compared with 25% of patients in the Andexanet Alpha group, had the primary outcome of death or hospice. And this was not statistically significant. We also saw no difference in the rate of hospital complications, with approximately 8% of patients in each group experiencing a hospital complication. And in terms of days within the hospital and days within the ICU, we saw no difference between the two groups. Additionally, a subgroup analysis was performed in patients who had that higher head AIS score of 4 to 5. And again, we saw no statistically significant differences in rates of death or hospice, hospital complications, or hospital days, though patients were more likely to experience death or hospice and a longer hospital stay within the higher head AIS group. And when we think about the strengths and limitations related to this trial, we can start with our limitations. We did have a lack of data in certain areas. The authors did not break down the number of patients who were taking apixaban versus rivaroxaban. We don't have any more specific information about timing from last dose to reversal, though one of the inclusion criteria was factor 10A inhibitor use within 2 days. If patients had thromboelastography or TEG performed, these results were not available. And we also don't know about the level of hemostasis or progression on follow-up CT imaging. Another limitation is intrinsically the retrospective nature of this study carries those limitations. There were some hospital formulary limitations. The authors reported on 30 of the 35 hospital centers related to formulary, and 10 of the 30 had Andexanet Alpha on formulary, while 20 of the 30 had four-factor PCC. We also are limited in our ability to apply the results of this study to patients who have a spontaneous bleed, because all patients within this trial had a traumatic mechanism of injury. And last, we have a lack of some of that really relevant, clinically relevant outcome data, which includes functional status at discharge. The strengths of this study, this was a large multi-center database that included level 1 and level 2 trauma centers, and they did perform a robust statistic evaluation. The authors concluded that in this patient population, which included traumatic brain injury, there was no firm conclusion that could be drawn between the use of four-factor PCC or Andexanet Alpha in terms of mortality in hospice or serious complications. The authors do state to interpret this conclusion with caution due to the limited sample size. There were a few things from the authors' discussion that I wanted to point out. They pointed to a systematic review and meta-analysis that was performed by Chaudhry and colleagues in 2022. This was an analysis of 36 studies, including over 1,800 patients, and they evaluated all-cause mortality and thromboembolic events with four-factor PCC and Andexanet Alpha, and they saw non-inferiority between these two agents. And then I want to point to the Annexa-1 trial. This was a phase 4 randomized controlled open label trial. This evaluated Andexanet Alpha versus standard of care, and when evaluating outcomes, they're looking at effective hemostasis at 12 hours. We can already see some different limitations of the Annexa-1 trial, including its open label nature and standard of care in this trial being receiving no agent for reversal. So overall, I feel that the study that we evaluated today in terms of traumatic brain injury was a well-designed study. I think they looked at an appropriate severity of injury based on the head AIS being greater than 2, though having a GCS of 6 and obeying commands is high, and that might be another limitation to applicability. The authors did evaluate clinically relevant outcomes, but I agree that having that functional score on discharge would be significant. And there are many other retrospective reviews and studies that have been released recently, which I didn't share the information on, but it's important to evaluate all of this literature as a whole. And last, I just want to acknowledge Brett Young, one of our emergency medicine pharmacists here at Nebraska Medicine, for his help in choosing a topic and reviewing this presentation. And if anyone has any questions, please feel free to reach out to me at any point in the future. Thank you.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.